Good evening, everyone. So, once again, we are back. I would like to invite you on behalf of IAP Allergy and Applied Immunology chapter for this very important webinar series, which is going on allergen immunotherapy foundations to frontiers. So, we have already discussed in the previous three webinars about the basics of allergen immunotherapy, that why allergen immunotherapy needs to be given, how it has evolved over decades or century, and who is the right candidate. We have also discussed that which allergen it needs to be given, which particular investigation is useful both at the initiation or during monitoring, and which modality of immunotherapy is good. We have also discussed about various allergen extracts, that how they are made, and there's issues about standardization. And we have also discussed about the Indian realities, that means from bench to the bedside, in the last webinar. And now today is a very important day in which we will be discussing further about the spatial population. We all are the pediatricians, or majority are pediatricians. So we'll be definitely discussing about this particular cohort where we can really make the change, where actually we are standing today and we can really make the change in the therapy in the disease. And then certain other different populations which are there, which we'll be discussing. So with me today, I am very fortunate to have Dr. Sanjukta with me. So Dr. Sanjukta is a senior consultant and head of the department at Peerless Hospital. She is a UK trained pediatric allergist and currently heading the pediatric department at Peerless Hospital, Calcutta. She has got several accolades under her belt, and currently she is chairperson of Pediatric Allergy West Bengal branch and respected EB member of the National Pediatric Allergy and Immunology chapter. So I think we cannot find a better moderator for this session today than Dr. Sanjukta. So Dr. Sanjukta ma'am, you are welcome, and please start your session.
Thank you, Dr. Gupta, for the very kind introduction and for giving me the opportunity of this program. So today, our topic, as you have said, is one of the most important things, because we are now talking about allergen immunotherapy in the real world, with special emphasis on special population and scenarios. And we have very well-known allergists with us today, amongst whom is Dr. Krishna Mohan, who is going to be starting today's first talk. He is the immediate past chairperson of the IIP Allergy and Applied Immunology chapter, and he's currently working as senior consultant at Kerala Government Health Services. He's an author of and chief editor of several books. Dr. Krishna Mohan is a leading voice in the subject of pediatric allergy in India, and we are very fortunate to have you, sir, to discuss the very first topic about treating the tiny, allergen immunotherapy in the pediatric age group, something that is a very sensitive topic for all allergists alike. Over to you, sir, for today's deliberations.
Good evening. Am I audible?
Yes, you are very much audible. The screen is being shared as well.
Okay, full screen. Yes. Is it full screen?
It's full screen, sir.
Okay, at the outset, let me thank the allergy chapter, especially the chairperson, Dr. Neeraj Gupta, the secretary, Dr. Narayan Reddy sir, and the treasurer, Dr. Ganesh Galovkar, for giving me this wonderful opportunity. I also thank Dr. Sanjukta madam for chairing this session and moderating the session. So I take this opportunity to congratulate the allergy chapter for organizing a webinar series in allergen immunotherapy, which is a much needed topic for the upcoming allergists in India. So in the next 20-25 minutes, I will be talking on allergen immunotherapy in the pediatric age group. So some of these the topics which I am discussing may be a repetition of what has been discussed, because this is the fourth day of the webinar series. You already had a lot of discussion starting from the basics of immunotherapy. So let us go into the topic. So in the next 20 minutes, I will be discussing these headings. First and foremost, why you consider immunotherapy in children, what is the evidence base, when to start, the recommended ages, and which one to choose, skit or slit, the safety concerns and the management of the risk, and some practical points, and finally some future thoughts. So to start with, starting with the fundamental question, why consider immunotherapy in children? What is the need of immunotherapy in children? As Dr. Neeraj Gupta told just now, this is the age group where immunotherapy has got the maximum importance. So when we consider the burden of allergic diseases, especially the respiratory diseases like asthma and allergic rhinitis, unfortunately, we do not have so many studies which presents before us the required data. What we have is the ISAC study as well as the recent GAN study. When we see this study, we can see that the prevalence of asthma in this age group, in the 6 to 7 years and 13 to 14 years, it is not that high. You can see it is only 3.5% in the age group 6 to 7 and 4.5 in the age group 13 to 14 years. Then still, why we are worried about this asthma in children? Even the GAN study, the recent GAN study also, they are reiterating the fact that the prevalence is roughly around 3 to 5%. But a very interesting thing to notice is that the DALY, or the death and disability associated life years per case of asthma in India, is 2.4-fold higher than the global average. Even though the prevalence is not that high, that decreased prevalence itself may not be true, because we may not be reporting all the cases to get into the database. That may be another reason. But still, if we see that the prevalence, even if it is low, the per patient disability is much higher when we compare with the international scenario. So what may be the reason for this? It can be due to a poor access to the healthcare, misdiagnosis, missed diagnosis, a delayed diagnosis, lack of prophylactic care, the poor socioeconomic status, the inability to afford the treatments like immunotherapy, all these things. So that is one very important point. Not only asthma, when we are considering allergic rhinitis, the prevalence is found to be high, that is around 11.3% in the 6 to 7-year-old and around 25% in the 13 to 14-year-old, which is comparatively higher when we are talking about asthma also. So this is about the ISAC test. So this points that the burden is high. The burden of respiratory allergies in Indian children is high. So we need something other than the simple pharmacotherapy. We know that the pharmacotherapeutic drugs, that the conventional drugs that we were using will act as a symptomatic tool, control tool. It controls the disease. But we really need something which will modify the disease. So that is where allergen immunotherapy has got a role. And this is the most important age group, or the most specific age group where you need to act. So what is the evidence? So the evidence base for the pediatric immunotherapy, there are a lot of studies available, not specifically from India. When we are seeing the international studies also, there are a lot of studies. There are randomized control trials, meta-analysis, even done by the World Allergy Organization, the AIT. They have done a meta-analysis. AIT has done a meta-analysis which compared around 98 trials. And there is another meta-analysis, the Cochrane meta-analysis also. But what is the summary of all these studies? The summary is that allergen immunotherapy, especially in the pediatric age group, is effective. Not only is it the sublingual as well as the subcutaneous routes of immunotherapy is found to be effective. It is decreasing the symptom scores, it is decreasing the drug scores, and the it is giving some benefit post treatment also. So that is the evidence regarding immunotherapy in allergic rhinitis and asthma in children. Not only that, we should always remember immunotherapy is something which acts as the root of the disease. Hope all of you are well versed with the concept of atopic march. We all know that atopic march is nothing but the peculiar manner in which the allergic diseases present, starting from the dry skin or atopic dermatitis, proceeding to the food allergies, allergic rhinitis, and asthma. So this immunotherapy has got a fantastic effect on stopping or even reversing the atopic marks. So the basic mechanism, you already discussed this mechanism of immunotherapy. It is by the induction of the regulatory T cells and the regulatory B cells. And by all these routes, what happens is that there is a shift from the Th2 mechanism to the Th1 or the normal mechanism, the atopic to non-atopic thing. So the most important thing to note is this, that immunotherapy addresses the immune dysregulation at the root of atopic diseases. And so it will definitely help in preventing the progression to new allergic conditions. So we do have so many studies which supports this. There is one PAT study, or the preventive allergy treatment study. There is another GRASAC study. It is a trial. Both of these which have proved that if you are starting immunotherapy sufficiently early in cases of allergic rhinitis, it will definitely halt the progression of the allergic rhinitis later turning on to become asthma. So the atopic marks can be prevented. That is a very, very important thing, especially in the pediatric age group. So it will prevent development of the new sensitizations. Even if you are starting immunotherapy with the house dust mite, ultimately it will in some way or other help to stop the development of new sensitizations, and later the development of newer and newer allergies will come down. Not only that, the beneficial effects of immunotherapy persist even after immunotherapy is discontinued. That is very important. Unlike a pharmacotherapy, the beneficial effects last at least 7 to 8 years, even 8 years after stopping of the immunotherapy is effective. That is very, very important. The evidence regarding the different allergens which has been used, we already told how effective it is, and the different allergens that we are commonly using, it has been shown that it is very effective against dust mite as well as pollen, and variable efficacy against the other allergens like animal dander, molds, and cockroach. But in dust mites, it is extremely useful. Now coming to another important point, because it is pediatric, so we should know what is the cutoff age to start. So when to start? What is the age and timing consideration? So both skit as well as slit may be considered in children over 5 years of age. Even though this is usually recommended as a cutoff age, as far as slit is concerned, it can even be started in a lower age group also, as low as even 2 to 3 years of age. You can start it, provided you have done all workup regarding internationally. All organizations are telling the cutoff age as 5 years, both for slit and slit, but slit can sometimes may be used as early as 3 years also on an individual basis. So behind this age limit, we are saying it cannot be used below 5 years. What is the reason why you are telling that you have to use it only after 5 years? So the thing is that younger children often cannot reliably recognize or communicate the early symptoms of the systemic allergic reactions. Though very rare, the side effects like anaphylaxis, even though it is very rare, especially in kids, it can occur. So young kids may not be able to communicate regarding the early features of anaphylaxis. And another thing is the increased fear, distress, which may lead to a poor compliance with the repeated injections. And the data is also lacking. We are not having the long-term safety data regarding this particular age group less than 5 years. So if you are considering sublingual immunotherapy below 5 years, careful selection and a specialist monitoring is mandatory. That is very, very important. In both allergic rhinitis and asthma, immunotherapy is most effective when initiated early in the disease course. In children with asthma, AIT should be considered only if asthma is well controlled. That is a very, very important point. We will be discussing that later when we discuss the safety of immunotherapy also. So a well-controlled asthma only can be initiated on immunotherapy, not a poorly controlled asthma. That is a very important point. Now, choosing the right modality, SCIT versus SLIT in children. So when we are considering SCIT, it is basically injections. So it should be done only in a clinic and it requires regular supervised visit for injections. Whereas a sublingual immunotherapy, it can be done home-based, except for the first dose, which should be given in a clinic only, and we have to observe for at least 30 minutes to 1 hour. So in SCIT, it involves injection, so it may be difficult for needle phobic children. In SLIT, it is simple drops or tablets, so it is very easy to be given. And for the parents also, SCIT requires frequent clinic visits, especially in the build-up phase. They may have to come on a weekly basis, and thereafter on a monthly basis, they have to visit the hospital. And this can lead to missed doses due to school absenteeism, travel, logistic reasons, etc. But sublingual immunotherapy is more convenient in this age group, reduces the need for clinic visits, fits better with busy family schedules. So the risk of non-adherence can sometimes be occur in SCIT, especially in the pediatric age group. Even though all cases of SCIT are monitored, there is a risk of non-adherence in SCIT. But SLIT, if suppose the parent is monitoring, and if it is parent dependent, the dosing will happen. They will give on a daily basis, they will be giving the drops or the tablet. Now coming to the safety concerns and risk management. Yesterday, you had a wonderful session on the safety of subcutaneous immunotherapy and sublingual immunotherapy from Dr. Deepthi. That was a comprehensive session where she covered everything about. So this next 2 slides is just a mop-up, I would say. This is just a summary of what she has discussed yesterday. So sublingual immunotherapy and subcutaneous immunotherapy, when we are considering the adverse effects, sublingual immunotherapy, the adverse effects are mainly local reactions. It can be oral pruritus or throat pruritus, mouth edema, stomatitis, pharyngeal edema, mild GI disturbances. Sometimes, very rarely, the EOE can lead to. Whereas the local reactions in SCIT includes redness, swelling, injection at the itching at the injection site, etc. Sometimes it can lead to the LLR or the large local reactions. That is also, these are all local reactions. When coming to the systemic reactions, especially anaphylaxis and major systemic reactions, it is almost 100% limited to SCIT. Sublingual immunotherapy is almost free of the systemic side effects. Very, very, very rarely it occurs. And even if it is occurring, it is not associated with life-threatening reactions or anaphylaxis. But in subcutaneous immunotherapy, there is a risk of anaphylaxis. It is very rare. Yesterday, she told it is around one case per 1.5 million injections. It can happen. So it is very, very rare. But you should remember that both subcutaneous as well as sublingual immunotherapy are not free of adverse effects. It can happen. And subcutaneous immunotherapy, there is a risk of anaphylaxis also, though it is extremely rare. So there should be a protocol how to manage the risk of before starting the treatment. So especially in subcutaneous immunotherapy, what you can do is that you can do a pre-injection risk assessment using, you can do a PFT, you can sometimes do a PFT, and only if the FEV1 is more than 70%, you have to go for this thing. In those cases of poorly controlled and not well-controlled asthma, better do not go for any form of immunotherapy. So you can use pre-injection risk as assessment like using a spirometry, or you can use some scores like the ACT score, that is the asthma control test you can do before doing immunotherapy. And when you are considering subcutaneous immunotherapy, always make sure that you are giving it only in the presence of a medical person trained in managing anaphylaxis, and you should have the sufficient facilities for managing the systemic adverse reactions like anaphylaxis. And it is a must that you should observe each patient after immunotherapy for a minimum period of at least 30 minutes, and all the resuscitative measures should be ready in your center, and you should make sure that only in such a center subcutaneous immunotherapy is given. Whereas sublingual immunotherapy, as I already told, the first dose has to be given supervised, and the patient has to be observed for at least 30 minutes to 1 hour after giving the first dose. That is very important. And you have to ensure a very clear communication regarding the home management, how they have to take the drug, some points regarding the adverse reactions which are expected, all these things. And as I already mentioned, it is very important to avoid in severe unstable asthma. So sublingual immunotherapy, as I already told, the side effects are mainly local side effects, local adverse reactions like itching, edema, some sort of GI disturbance and all. Majority of these side effects will be occurring around within 1 or 2 hours of starting the treatment, and usually it lasts only around 10 to 14 days of starting the treatment. After that, it will subside, and all these local reactions are very well controllable by using antihistamines, as well as especially in the kit you can use cold compresses. All these things will help. And regarding the systemic reactions which are expected in subcutaneous immunotherapy, you should be well aware of how to manage an anaphylaxis, and adrenaline should be ready, the dose, everything should be known to you. That is about the presentation. Finally, coming to some practical points, some practical pearls when we are thinking about immunotherapy in children. So first and foremost thing is that the communication with the parents is very, very important. So you should not give any unnecessary guarantee, or you should not give any unnecessary promises. They should understand that it is not a quick fix. This is not a quick fix. It will time. So they have to understand very clearly that this is a chronic disease, and the treatment in the form of immunotherapy will take at least 3 to 5 years for optimal effect. It's not like that you take this drug and after 1 week you will be normal. So that point should be very well communicated. And the mechanism of immunotherapy should be communicated very clearly. You have to use very simple terms rather than telling T regulatory cells, B regulatory cells, atopic march, all those things. You have to tell them very simple terms like we are going to teach the immune system to stop overreacting. So allergy is like an overreactive system. So what we are doing is that we are trying to reverse it. You're making the immune system to stop overreacting. And you have to clarify the safety profile. There also, you please do not give any unnecessary promises or something. You have to tell, especially when you are giving subcutaneous immunotherapy, you have to convey it very clearly that there is a risk of serious reactions, including anaphylaxis. But even if it happens, you can manage that. That also you can tell. And regarding adherence is extremely important. So a very good communication itself will help to improve the adherence. So one practical point which you have to remember is that a non-adherent patient to pharmacotherapy may be non-adherent to immunotherapy also. So that may predict a poor outcome with immunotherapy. So that you have to keep in mind. And finally, another important thing which is very, very important, especially in India, you have to discuss the cost of the treatment and commitment early. Be transparent about the cost implications, because majority in India, we do not have, until now, we do not have the insurance coverage of immunotherapy. So they may be starting the treatment, but after a few months, they will feel that they are not able to afford. So that should not happen. So the beginning itself, we have to tell them very clearly that the cost of this, the 3 year course, you have to tell them. And you should always remember, you're not only an allergist, when you're also a pediatrician, so you should check all the basics. Growth monitoring is very important. So monitor height, weight, and the BMI each follow-up, and ensure that there is no faltering growth, because some of these kids may be on long-term oral steroids. Even without your knowledge, they may be on long-term oral steroids, they may be having FTT, all these things you have to take care. So nutrition also, you have to assess that. Dietary intake you have to assess. And suppose the patient is having a concomitant food allergy, they may be on a very, very restrictive diet. That also you have to take care. And immunization, which is very important, especially against the respiratory pathogens like the flu vaccine, pneumococcal vaccine, all these things you have to take care. And other aspects of immunotherapy, as far as possible, use when you are giving sublingual immunotherapy, try to use the same allergen which you did the skin prick test also. The prescription may be varying between doctors, and you should always remember that it is always better to limit the number of allergens to start immunotherapy. Yesterday also you discussed that. So monotherapy works best rather than mixing all the allergens which you found it in the skin prick test and giving immunotherapy. Try to limit the number of allergens. Monotherapy works best. So maximum 3 allergens at the most. And again, I reiterate the fact, counseling the patient and family is extremely important. And the contraindications, this is very, very important. This slide is very important, especially in pediatrics. You have to keep this in mind before you start immunotherapy. So absolute contraindications, as we already told, any case of uncontrolled or severe asthma is an absolute contraindication. And a history of a recent severe anaphylaxis to the allergen is a contraindication. Immunodeficiencies, primary immunodeficiencies, malignancies, active autoimmune diseases, ongoing beta blocker therapy, all these conditions are having a potential to increase the risk of allergic reactions like anaphylaxis, and they are contraindicated. And consent, this is very, very important. You have to take a written consent. And these are some practical points which you should remember. This is not only for immunotherapy, even for a skin prick test, you have to take a consent. Consent should be in the same pen, same ink, same time, and you should make sure that the patient or the guardian has understood the language, because you may have written it in English, but the patient is not able to understand English. So that is not good. You have to write it, if possible, you have to write it in the local language and make sure that they have understood what it is written there. And you should include the worst case scenario also, including anaphylaxis. You have to mention the consent, and include in the consent that all necessary precautions to be taken after testing and treatment is well explained. So regarding the consent, we already have some ready-made forms. This is one consent of skin prick test. This is the second one is a consent which we are using for the sublingual immunotherapy, subcutaneous immunotherapy also we can make a consent form. So if you want, you can scan this courtesy to Dr. Vikram Patra, an allergist in Navi Mumbai, one of our VB members for uploading this and making this QR code. So this is very useful. You can download these consent forms if required. You can modify that later if you want. You can modify that in local language. Nowadays it is extremely easy because we do have all these AI tools like ChatGPT and all. You just have to upload and give an instruction or give a prompt. Within seconds, it will be converted into the local language and you will be getting that. So finally, coming to the future directions, what all things we have to keep in mind for future. So at present, we are having both subcutaneous immunotherapy and sublingual immunotherapy, but even now it has not reached a stage where every patient in India is able to get that or access that. So there are a lot of limitations as of now. So what are the future directions regarding immunotherapy? So one very important thing is regarding the standardized allergens. So not only for immunotherapy, also for skin prick testing, standardized allergens should be made available freely, and there should be some system to periodically assess the quality of the allergens. That is very important. The recent advances in diagnosis and management of allergic diseases should be made available in our country. And the third point is very important, a very good knowledge of anaphylaxis and availability of EpiPen or some other device like that. A auto injector is very, as of now, EpiPen is not freely available, and even though it is, we are procuring it through some agents or through the online sites, it's very costly. So there should be some system where we can get this EpiPen at a less cost, and it should be freely available also. This is very important. Medical insurance programs should cover allergies and asthma. As of now, if we write the diagnosis of asthma, we know in our hospital, in our government hospital, they are getting some insurance. So if we write pneumonia, they will give. But if we have written asthma along with pneumonia, they won't give the money. That is a very, very practical difficulty. So medical insurance programs should cover allergies and asthma. Some steps should be taken in that direction also. More funds should be allocated for dealing with allergic diseases in the national budget. So these are certain things which IAP can do, the allergy chapter can do by giving some letters or some request, it can be done. And regarding the training, we have still not reached the required number of allergists to treat the number of patients of allergy, asthma, and allergic rhinitis and other allergies in the country. So we need more and more subspecialty training programs exclusively dealing with allergy. Immunology of allergy and allergic disorders should be an integral part of the undergraduate and PG curriculum, and good quality research also should happen. So this is all about my presentation for today. Thank you so much for your patient listening. So I think the questions, Madam will be taking at the end of the session.
Thank you, Dr. Krishna Mohan. Thank you for this very comprehensive yet brief look into the subject and highlighting all the important points. We have a panel discussion at the end, I think, where we can take the questions, because then all three experts would have already opined. So has Dr. Shoibal Mitra joined?
Has joined. Sir is there.
Okay. So Dr. Shoibal Mitra is our next speaker. He has not been keeping very well, so I hope you feel better. He's a leading allergist, clinical immunologist, and pulmonologist, currently working at Apollo Multispecialty Hospital in Kolkata. I've had the honor of interacting with him several times, and he's among the top few researchers in the field of allergy. I am spellbound at the number of citations he has, over more than 650, and H-index of 14. So he's a very humble person. And whenever I listen to Dr. Moitro speaking, I always learn something new. And he has always been a great friend to all of us whenever we have needed any idea about any patient to treat. So it's an honor to have you, Dr. Moitro. So I hope you've got your presentation ready. And if you can start sharing the content, we will start.
Yes, definitely. Okay. I hope my screen is visible to all.
Yes, it is visible, sir.
Yes. Okay.
Yeah, it's on a slideshow mode.
So at the first, I'm really humbled by the kind words of Dr. Dey. So thank you so much. Okay, and moreover, I really thank the Allergy and Immunology chapter of Indian Academy of Pediatrics for inviting me to deliver a talk on this very much needed, and it is almost means we all want to do an immunotherapy. So it's very much needed at this topic and webinar series on the allergy and immunotherapy. So I really had a very extremely beautiful session and very comprehensive and very composed way of talking by Dr. Krishna Mohan. So we all have got to learn many nuances of the allergen immunotherapy that he had just discussed. So thank you, Dr. Krishna Mohan. So I would be starting, and my talk in the next couple of minutes would be mainly dealing with an allergen immunotherapy, something beyond of what we do for usually we said allergic rhinitis. So it's a little bit of a futuristic and some other aspects of the immunotherapy which is coming under its forays. Okay, so this is very, very important because we now understand that as we are heading forward to an era of a personalized medicine, the precision medicine, so-called one of the most important precision therapy which we have in our hand is an immunotherapy, which is as precise and as personalized as it can be in today's omics era. Okay, so only I would say that its applicability has not been harnessed adequately. Why? Because we still need to have more and more evidence for that, number one. Number two is we're understanding various other hitherto unknown mechanism of action of the immunotherapy, and that is truly amazing. Means we just get to know that what an immunotherapy can do in a particular patient, the right patient with the right allergens and doses like that. So with this, let me begin. So I have nothing to declare in context of this talk tonight. So this is a very common diagram, and it was published in 2021 in Allergy. I like it very much. How this allergy tree is growing. Okay, and so maybe it was a small sapling 100 years back. Now it has grown to a big tree with the trunks and the branches and the leaves and this foliage all over, and taking more and more patients under its shade and giving comfort to more and more patients. It's so interesting, if you think in that way. So it was a Noon and Freeman's empiric observation more than 100 years back when they actually treating with for a means the pollinosis and the hay fever, and they found that it really works. And there is a very, very nice, actually, it was a commentary which was given by the Noon, Leonard Noon, and that is well freely available in the PubMed, and also one can just go and have interesting read on that. Actually, Franklin first did the double-blind placebo-controlled trial and showed that this really works. So after that, the journey has been great. So it has been in leaps and bounds with more and more evidence which is coming for the AIT. And as we ushered into the era of the evidence-based medicine, we knew that the evidence were not only coming in from the actually a particular disease, but also from various other diseases, and also from the diverse communities all over the world. And so it was not only allergic rhinitis, there were other diseases which was coming under it. And then there was mainly more and more research into the mechanisms of the AIT, the pivotal trials, mainly the big trials which we call for the AIT, which happened in Australia and the US and in the Europe. And then came the position papers, the guidelines, and also the newer application and methods, the allergens, the roots, and the new diseases which was coming. So it is like the tree is still growing. Okay. And so we get to know that maybe it would become the big banyan tree as we have it in Calcutta, in our botanical gardens. It would be like one of those in the time to come. It's already grown to a large extent. So if we see that this timeline, first of all, it was in 1911 when there was the Leonard Snow and Freeman's observation. But after that, when we proceeded over the period of time, we see that there was mainly for the allergic rhinitis. So that means the disease which was mainly caused by the pollens. So it was a pollen-induced allergic rhinitis or a hay fever, which was treated by the allergic immunotherapy. But then, as we understood more of the disease pattern, like the allergy is not a particular disease entity, but it is a mechanism. It is an underlying mechanism which gives rise to various disease entities during the course of time, which may happen one after another with a temporality, or it may happen all together like a multimorbidity, or maybe it could happen one disease to another, then again come back. So like something which is just dancing around the various organ systems. And after that, one of the most dreaded disease which was thought of is asthma, because of the amount of the suffering which it brought to the patients and the magnum of the disease burden in the entire world. So there was a big actually interest in that. So when scientists or clinicians understood that actually having allergic rhinitis, or maybe an atopic dermatitis, or maybe food allergy early in the life can pave the way for respiratory allergy or asthma later on, then is this AIT would prevent the asthma. So its role as an asthma prevention came with this Gazax asthma trial, this preventive asthma trials and pattern and gap trials. And we have some good encouraging results, but we now understand that there are many other factors which determine the progression of the disease and its manifestation in a particular individual. It's not only the genes, but it is how the gene is interacting with the patient's environment. That is, the exposome plays a very important role. But still, this is one of the main area, and the focus is still going on. So this is still going on, and we have some very good results that it prevents the severe form of the disease of the asthma later on. It's mainly from the Gazax asthma study. So then there was this novel approaches, and there was the use of the allergen immunotherapy in the various other diseases which was coming one after time. This is a very basic slide, just to put the entire thing into the perspective. So we know that when there is an allergen exposure, so allergen is taken up by the dendritic cells, dendritic-presenting cells, and it presents it to the naive T cells in the secondary lymphoid organs. These naive T cells are activated by various activating signals, which is given by the dendritic cells, and it then transforms into effector cells. So we know that the main effector cells that we talk about in the context of the allergies are the T helper cell, that's the T helper type 2 cells, and the T follicular helper cells. So T helper type 2 cells, it releases the type 2 cytokines, the signature cytokines, IL-4, IL-5, IL-13, IL-9, and this all helps in actually stimulating a type 2 immunity. So at the same time, this T follicular helper cells, the release of the interleukin-4, interleukin-21, and then in the germinal center reaction, it causes the B cells to undergo the somatic hypermutation, the affinity maturation, and the isotype switching to the IgE. This IgE is then synthesized by the effector B cell, that's the plasma cells. It goes and binds to the high affinity Ig receptors on the mast cells. And when the allergens again comes into the system, it binds to the mast cell bound high affinity Ig receptor, IgE, it binds to them, and there occurs a cross-linking in between the bound IgE, and this leads to the conformational changes and downstream signals, mainly involving the STAT4 pathway, and leading to the degranulation of the mast cells and the release of the various as chemical mediators for the type 1 hypersensitivity disease. We all know about this. So I was just refreshing the thing. In allergen immunotherapy, the classical pathway, or for that matter, the main pathway that we all talked about, is the generation of actually a regulatory phenotype or a regulatory type of the immune system. And there actually it leads on to the generation of T regulatory cells It leads on to the generation of the B regulatory cells. It leads on, nowadays we know that there is a regulatory phenotype of the dead dendritic cells. There's a regulatory phenotype of the innate lymphoid cells. So this is mainly the generation of the regulatory cells, which occurs because of the high dose of the allergens, which is being given during the treatment. And this regulatory cells, it sends the suppressor cytokines, namely the lipid 10 and then the TGA beta, and also by the action of the cells themselves, with the cell-cell interaction, it leads on to the dampening of the T2 response. And at the same time, later on, slowly, there's a shift from the Th2 development to the Th1 development in the secondary lymphoid organs. These are the Th1 cytokines, namely the interferon gamma, and which brings about the abrogation of the entire allergic immune system. So this is the main thing that we have. So with this keeping in mind, we'll just move forward. Okay. So what newer developments which took place? Okay. First of all, a very, very interesting thing which has just come up. Now, we all understand, as Dr. Krishna Mohan was so rightly talking about, one of the biggest concern that we talk when we're giving an allergic immunotherapy is the safety. Okay. Because we know that whenever we are giving the allergens, it has two aspects. One is the immunogenicity and another is the allergenicity. Immunogenicity means we mean to say that it is going to interact with the immune system and it is going to bring some changes in the immune system. That is the immunogenicity. Okay. And allergenicity is that it is going to give a T2 immunity, leading on to the formation of the T2 cytokines, entirely the T2 cells coming into the picture and causing the T2 side effects, namely we all think about the anaphylaxis. Okay. So there was the newer trend is to separate this immunogenicity from the allergenicity. Okay. Just like, similarly, an analogy if we give is a vaccine development. Okay, the vaccine development, we all know that the wild type of any bacteria or virus, it causes the disease. But what we tend to give in the vaccines, we tend to give in the vaccines maybe an attenuated live virus or an inactivated organism, it's a dead organism, or maybe a subunit of that, or maybe a nucleic acids of that, so that they maintain the immunogenicity, but they do not cause the disease. Similarly, in case of the allergic immunotherapy, the development was that we actually give the whatever we are giving, I'll just talk about it, so that it can actually activate the T cells and modulate the T cell function without actually going and causing the B cell activation and leading on formation of the IgE and the allergy. So that was the main idea. So there was many things like it happened like one, it started with a recombinant hypoallergen, and here the epitopes, so these are all the conformational epitopes, where they were molded in such a way so that they give rise to the formation of the IgG and also activated the T cells, but not the IgE. Because for an allergen to be capable enough, or for the matter antigen to be capable enough to give rise to production of the IgE, it needs is the interaction of some component, the factor of the host, and also the factor of the protein structure. Okay. Now, which allergens are allergens actually? What is unique about it? There's a very beautiful paper by Brittender. So, and he has discussed so nicely. There's nothing like, okay, only this structure or this motifs is going to give allergy and that motif is not. But it depends on the context in which that motif is presented, number one. And second is in the host, how the host immune system is modulated. But there are certain more hyperallergenic motifs, certain hypoallergenic motifs. So actually these are modulated in this, the recombinant hypoallergens. or it could be like a native, like the recombinant allergens, where actually it gives rise to both the IgE, IgG, and T cell, but there is changes more towards the later on, that is, it causes more or like increased a dose of is given so that it attenuates the IgE response and increases the IgG response. Then we had this T cell epitope containing peptide. These are the linear peptides, and so which can only activate the T cell. They do not have the conformational peptides which activate the B cells. So once the T cell is activated and modulated, it forms the regulatory T cells. But since there is no conformational epitopes, so that means it cannot actually activate the B cells. So the T cell B cell cooperation, which is needed for the full, well, actually the picture of an immune reaction of the humoral and the cellular immunity in adaptive immune system, does not take place. So it's only the adaptive cellular immune modulation, and that to a regulatory modulation, which can be achieved by only a T cell epitope containing peptides. Interestingly, the virus-like particle coupled allergens, which is now being used for the cat allergens and all. Similar thing, that it's virus-like particles. When the allergen is put into it, its processing becomes totally different. Okay, because these particles are not processed by the usual lysosomal pathway, but they're actually processed by the proteasomal pathway. The proteasomal pathway, actually, it gives its rise. They're presented with the MHC class 1 and not the MHC class 2 proteins. And so they mainly activate the CD8 positive T cells. And and also it causes the generation of the IgG. So this is another thing. And there's something like carrier-bound B cell epitope containing peptides. These are the carriers which has a B cell epitopes, but they do not have the T cell epitopes. So what happens is that B cell does not get the help of the T cell. So though the B cell are an antigen-presenting cells, there's actually some activation of the cell to take place, and they actually leads on to the production of the antibodies, which are not of the IgE but of the IgG. So this kind of analogy, this is which have been taken up from some of the PIDs, like this common variable immunodeficiency, but there is no T cell help, only B cell, and producing IgG mediated IgG antibodies of lower affinity means not underwent somatic hypermutations and less effective. So this is one of the things. So then there were recombinant allergen-specific IgG blocking antibodies. These are mainly of the IgG subclass 4, and these are mainly given like some kind of like a passive transfer of the immunoglobulins, which can render an individual hypoallergenic. Or maybe the allergen encoded in nucleic acids, where they were incorporated like these nucleic acid vaccines, and which encoded and released the formation of the proteins, and which mainly lead on to the IgG and the T cell. Or maybe the allergen-coupled immunomodulatory compounds, like which can actually cause a regulatory phenotype to come up, and IgG. So these are all the various newer things which is in the pipeline, and some of them are also in the clinical trials as well. And this recombinant allergens, this AIT, so this has actually changed and also changing the scenario. So this is the conventional scheme of the subcutaneous immunotherapy. That is, we have a build-up phase. That is, it is build up to the maintenance dose over a period of maximum of the three months, or it can be a more rapid build-up. And then the maintenance phase, injections are given usually on a monthly basis, and this runs for 3 to 5 years. But now the schema has changed. The recombinant schemes of the AIT, where this recombinant B cell epitope grass pollen vaccine, or it could be a recombinant hypoallergenic fragment and of various other pollens, and which is given only maybe just before the pollen season, and a one dose just after that. So this is just a pre-seasonal and one post-seasonal immunotherapy, it suffices the thing, because there actually generates enough of the regulatory phenotype so that when this actually this allergen comes inside, and when there is already a regulatory phenotype which is there, which is going to dampen the reaction. And very interestingly, there's a very important concept in this. So there's a known as a concept of the immunological sin. You know what is the immunological sin? Immunological sin is, see, it happens in cases of the viral infection like influenza. So what happens is that when a virus has actually infected a human being, so then there's a primary immune response, we all know, and then there's formation of the memory cells. Okay. Now the primary immune response, the immune system or the T cells, it recognizes all the various epitopes, and it also activates the B cells, generates antibodies, and the antibodies is with the innate immune system cells and the adaptive immune system cells, it fights the infection. But what happens in this next the secondary infection, this class switched based antibody is produced by the B cells, which are now the memory B cells and also the memory T cells. They usually get activated very rapidly. But there's a very important component in that. The important component is all the naive cells which are there, they actually have a very important receptor on its surface for the IgG, that is the Fc gamma R2b1. This Fc gamma R2b1, what it does is that when there's an antigen-antibody complex and that IgG binds to the Fc gamma R2b1 in the T cells, it gives a negative signaling to the T cells, and those T cells are prevented from getting activated. Similar thing happens in this case. The recombinant scheme of the AIT is that when the person has already developed an IgG, person has already developed a memory T cell and a memory B cell. So what happens is that they react rapidly, but the antibodies which are generated IgG, so when the allergen, or maybe for that matter, maybe an IgE or whatever it is, when the allergen is again going inside the body, and that antibodies are again, gets stuck to the allergens, and they goes and binds to the T cells, also with the Fab, with the Fc portion receptor on the T cells, they get down-regulated. So they gives a negative signaling for that. So very interesting mechanism, and which has come up very recently, and this is a paper published in the Cells in 2022. So this gives rise to a very personalized mechanism of the allergen immunotherapy, so that it's not a blockbuster treatment that is a one-size-fits-all. No. So now we have, depending upon the various characteristics of the individuals, depending upon their not only their genetic structures or genetic signatures, which we get on the basis of the transcriptomics, metabolomics, and the genomic studies, but also the exposomic studies and the entire thing. There's a very personalized medicine, and in them, not only the type of the vaccine, but also the various other factors comes in, that is the individual's disease, the lifestyle, various habits, and the environmental condition in which the patient is there. So this brings to a very interesting phenomenon now we all talk about, that once we have started, when to stop and when to go ahead. So there may be some early stopping rules, and there are some late stopping rules. The early stopping rule, we say generally it comes up at the end of 1 year, when we say that the person has not improved much. So not improved much clinically, given by the combined symptom medication score, which remains more or less the same. And immunologically, if the patient sensitization numbers are more or less the same. And also at the same time, maybe the patient has had some side effects to the immunotherapy. We stop the immunotherapy there. These are the early stopping rules. And the late stopping rule is maybe patient disease is well controlled, patient symptom medication score are very low, patient immunologically, patient sensitization levels are also dropped down. Then should we stop at 3 years? or should we continue at 5 years? All depends upon the patient choices and the disease in perspective, and also what is the entire scenario. So these are some late stopping rules are there. So this all focuses on where are we today. That is, we have the multiple routes of the immunotherapy. We have the various newer components of the immunotherapy. We have various monoclonal antibodies which is coming, and we added with the immunotherapy, and we have the risk prevention and concept of the immunotherapy in the context of the AIT today. So with this, when we go ahead, we see now there are a number of diseases which is coming under the ambit of the immunotherapy. We all knew it's allergic rhinitis. Now, let's see what in asthma. Okay, so we all said that yes, there is a subset of the asthma patients who will definitely benefit from the immunotherapy. But who are these? So we know that asthma is it has multiple phenotypes. So maybe a T2 high asthma, obviously, they are the candidates for the immunotherapy. They initially, still the guidelines is on they should have an allergic rhinitis, they should have a perennial allergens, which is not only triggering the disease, but also causing and maintaining the disease in that particular children. That is important. But nowadays we're moving ahead, and we are seeing that more and more, well, if it's a T2 high asthma, okay, they can be brought into the immunotherapy. This was a very yucky guideline, post-viral immunotherapy. They said that, well, uncontrolled asthma, we do not treat with the AIT. Controlled asthma, we treat with the AIT. But this, in the middle portion, there is partly controlled asthma. So partly the controlled asthma, as per the GINA, this is a very new thing which has come, that we can add an HDM AIT facility achieving asthma control. But remember, there should not be an severe exacerbation in the past 1 year, and FEV1 should be more than 70% of the predicted. Or maybe we can achieve the asthma control and then go ahead with the immunotherapy. But this thing is coming more and more because we want to start the disease-modifying treatment as early as possible. So this is for with the conventional pharmacotherapy, with or without biologics, that now its role in asthma has become more and more obvious. So number one is prevention for the onset of allergic asthma. Still, there are many more studies to come up, but we have now very good evidences for that. Or if the asthma is worsening, the patient is not getting well controlled, we can achieve control or partly control, we can add, or maybe from the treatment point of view, definitely prevent and the actual progression of the disease. This is very recently, this was a paper in the clinical experimental allergy in the last year, 2024, it came. So with this, all the subjective outcome measures, symptom scores, medication scores, so definitely there is decided upon the treatment one. Importantly, still lacking is the biomarkers. So which are the biomarkers which will show the efficacy to the immunotherapy? Is it at the decrease in the Ig level? It's absolutely not. So is it the increase in the specific IgG4 level? Itself, it is fraught with many actually discrepancies. So it could be a specific Ig or specific IgG4 levels. It could be the increase in the interleukin-10 levels, but they have not come into the clinical practice. So still now, combined symptom medication and score holds the ground. So if you see into the GINA 2025 guidelines for adults and adolescents, there is a line over here, allergen immunotherapy HDM slit. It can be considered along with the regular controller medications to achieve what we have said. Why it is house dust mite? Because house dust mite has been shown to actually important in causing and progressing the airway inflammation and maintaining the airway inflammation. And why the slit? The slit is more safe regarding the evidence of the safety for slit is more. And there was a Cochrane review which showed that for the seasonal allergens, kit may be somewhat fared better, and for the perennial allergens, the slit is better. And anyway, for the evidence-based safety issues, was slit, it was written, and GINA UNIS always has been very conservative in all these approaches. Now, very interesting thing, there was this systematic review and meta-analysis. I had only took hold of this is because this gave a long push, much needed push in the treatment of atopic dermatitis, a disease fraught with so much of men's frustrations. So there was a it was a review published in JACI 2023, 23 RCTs, of participants, and they have shown that yes, SCIT and SLATE have similar efficacy in reducing the eczema severity, in improving the quality of life, and though there can be some local reactions. So for the ocular allergies, this was one of a paper published by our group, and we showed that the indications has been shown to treat in the allergic conjunctivitis extensive and demonstrates effectiveness in alleviating ocular symptoms, reducing medication usage, improving quality of life in patients. Both and SCIT has shown positive results. And now we have in the guidelines coming with both in the vulnerable keratoconjunctivitis, seasonal and the perennial allergic conjunctivitis, the role of the AIT is there. Or from that, which I have not touched upon, is basically the role of the oral immunotherapy in treating the food allergens. That's totally different ballgame altogether. And obviously, very, very important is the venom immunotherapy for the stinging insect allergies. So you see there is so much thing which has come up and which is still underway. The local practice, we know that from Indian point of view, SCIT has more evidence. It is coming up in a big way. Conventional regime is most commonly used. Allergens are non-standardized, but they're efficacious. And this house dust mite slate has also become available. But very important, as Dr. Mohan has stated, it has to be consent. All the parameters has to be taken, all the boxes needs to be checked, and then we embark the patient and telling them the cost of the treatment and how long it is going to be. So very important statement which Dr. Mohan gave. The patient who has not been compliant with the pharmacotherapy is not going to be compliant with immunotherapy. So please don't start a non-compliant patient on pharmacotherapy on the AIT. Thank you very much.
Thank you, Dr. Moitro, for that wonderful deliberation. And as usual, you go into all the scientific details. It seems that I'm attending a postgraduate class once again, but thank you very much for that. So our next speaker would be Dr. Oratrika Dash. She is a senior pulmonologist, allergist, and immunologist from Kolkata. She is a well-respected figure in the medical community due to her extensive knowledge. She was one of the first persons I came across in Kolkata who was doing allergen immunotherapy and practice. So she is here with us, and we are very fortunate that she has some time to spare in her busy schedule and talk to us about some of the special situations that we face in allergen immunotherapy. So Dr. Oratrika Dash, over to you. And if you have PowerPoint presentations, please share your content and we can get started with your talk. Dr. Oratrika.
Thank you, Dr. Yeah, I'm here.
Yeah, you're here. Thank you.
Can you hear me?
Yes,
Yeah.
yes.
Yeah, okay. Let me share the screen first. Just a sec. Please give me some time. I'm trying to share the screen.
Yes, please.
Yeah. Can it be seen?
We can see a screen with Zoom written on it. Now
I have resumed the share.
Minimize
I-
your Zoom. You minimize your Zoom.
You minimize your Zoom and
Okay.
share.
Your Zoom screen is visible, ma'am. You please minimize your Zoom.
Just I'm trying to.
Ma'am, from the right hand side, top corner, ma'am.
If you go to right hand side, the minus
Yeah.
sign, if you minimize that
Okay.
and then share the rest.
Yes, ma'am. Please click this, the minus side.
Yes, 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 yes. That's one.
Okay, just try to.
Just
Yes, ma'am. Once again, the minus sign. Once again. Or otherwise, try to cross it, ma'am. The red cross. Try to cross, ma'am.
yeah. Okay.
Yes. Now you share your screen.
Okay. Yeah. And
Have you opened your PowerPoint on the screen, ma'am?
yeah, I
Okay.
have.
Please share. Please share.
It has not yet been shared. I have opened
No.
it already. Just- Again.
Yes. Now it is
Now-
shared, ma'am. Yes,
Now,
it is.
yeah, now successful.
Please go on the slideshow.
Just click
Yeah,
on the
I'm putting it
slideshow.
on the slide share.
Huh.
Is it visible now?
It is
Ma'am, not on the
visible.
slideshow.
We can see as slides, but if you can
I have
click
put
on
it on the
slideshow.
slide. I have put it on the slideshow only.
Okay.
Hmm.
Just if you go to the top and just click on the
Okay.
slideshow again, next to design animation, the slideshow, right on
New
top.
share.
Home,
Let me
insert,
see.
design, animation, slideshow. Just click on the slideshow, please.
Now can it be seen?
No, ma'am. You just can try on the top. There are few names like home, insert, design, animation, slideshow. So please click on the slideshow.
On the top left-hand side.
Animation slideshow.
Yes, it says place on the slideshow. Next to animation.
I can only find
Just
this.
go for the home, look for the home. Next to that is insert, design, then
Yeah,
animation,
yeah.
then slideshows. On the top bar.
Yeah, the top bar, just a sec. The top bar cannot be seen properly. Just let me, okay. Yeah. Yeah, slideshow.
Just click on that, please.
Yeah, click and set up slideshow, right? Mm.
From current slide.
Ma'am, if you are
I've-
unable to, so please start, ma'am. No problem. So you start like this only.
You
No,
start, yeah, it doesn't matter. At least you
start like
can
this only, ma'am.
read.
Please start.
Can you see this at least?
Yeah, we can see the AIT special population.
Yeah.
We can see the first slide and you can go to the next slide also. Yeah. You do from
You
there.
can't see this, right? The whole
We can't see the
slide
slideshow, but doesn't matter. If you
share.
can choose the slide one after the other and do it, I think it will be fine.
Okay, okay. Then I think I'll start. Okay.
Yes, please. Yes, please.
Now, good evening to all of you, and my heartfelt thanks to Dr. Neeraj and his team. Thank you very much. And I have just heard two of the lectures by my precedents, and I think my talk will be shortened down to 10 minutes or 15 minutes because many of the slides are in common. Of course, we have been on to allergen immunotherapy over the past few days. So slides are bound to be common in certain ways. And I have been assigned the task of speaking on AIT in special population. Right. So I go on to the next slide, which is, I'm sure, is difficult for you all to read it, probably. But anyway, I'll read it for you in the sense.
Slides are not moving, ma'am.
You
Have
haven't
gone on
been
to
able
the
to
second
see?
slide? Have
Oh,
you gone on to the second slide?
yeah. You can't see that.
No.
Oh, just one second.
Resume slideshow. Yeah, now we can see it. Yeah.
Can you see it now?
Yes, we can.
Now, of the full length, full
Yes,
as a slideshow. Okay. So before going on to the main topic, just I'd like to say some of the indications and contraindications of allergen immunotherapy, because this will be probably of use while deciding regarding immunotherapy in pregnancy and PIT. So, of course, the indications are very crisp: allergic rhinitis mainly, allergic asthma, and bee venom allergy. Nothing much to elaborate on this, but I'd like to talk about the contraindications more, and which Dr. Shoibal, I think, also has dealt upon. The absolute contraindications of allergen immunotherapy being, of course, most important is uncontrolled or severe asthma. The second is patients who are immunocompromised, patients who are diagnosed with malignancies, refractory active autoimmune diseases. Immunotherapy also cannot be initiated in pregnant women. Eosinophilic esophagitis, these are the absolute contraindications. But in the relative contraindications, we can see, I don't know whether you can see it, patients with primary immunodeficiency, they are relatively having contraindications for allergic immunotherapy. And why I'm saying this is because I'll speak on that slightly later. Okay. This is a very familiar slide. Can you see it?
I think we'll have to resume. Press on the
Again,
resume. Yes,
again.
yes. When this happens, I think that is the only thing that works. So you just press on resume slideshow again. We'll see the next slide. Yes. If you keep on doing that for every slide, I
Can
think
you see
it'll
it
work.
now?
Yes.
Yeah. So this is a very familiar slide, just denoting we've been going through this since the past few days, and this basically denotes how the allergen being taken up by APC, presented to T naive cells, turning them into Th2 types, which again from where the interleukin 4, 5, 13 are released, which act on the B cells. Finally, IgE production, IgE antibody production, which bind to the mast cell receptors. And whenever there is a second exposure to the allergen, the mast cell degranulates, and a lot of histamines, leukotrienes, other prostaglandins, PAF, they pour out, giving rise to the symptoms and signs of allergy. This particular slide has already been shown and spoken on by Dr. Moitro. I would like to point on the side where how allergen immunotherapy helps in bringing up the tolerance to one particular allergen. Now, what happens when during allergen therapy, immunotherapy? Actually, a large amount of the allergen is actually given to the patient in the patient system. And in the initial phases, there is a transient rise in IgE production, which comes down very soon, followed by a rise in immunoglobulin G1 first, and then a subset of immunoglobulin G, that's G4 production. And what they do is they further cause the production of TGF alpha and IL-10. And it is this IL-10 which is most active during this allergen immunotherapy period. And that causes, basically, that acts on the plasma cells. And again, causes further increase in IgG4 production. Also, IgA has also been shown to have a role in allergen immunotherapy induced tolerance, especially the subset of IgA, IgA2. So this needs to be kept in mind also for, so that we can explain how allergen immunotherapy, in which exact cases allergen immunotherapy can be of help and in which cases it may not be of help. Okay. So again, I go back to the
Resume slideshow, yes.
Yeah. And can you see this now?
Yes, immunotherapy during pregnancy.
Yeah. Just... Okay. So we come on to a part of the main topic, that is immunotherapy in pregnancy. These are just the initially I'm telling you just the recommendations which have been given by various studies and guidelines. So, yeah. Oh, wait. Yeah. Can you see this now? Well, Sanjukta, can you see this?
Yes, we can see. We can see. We can see allergen immunotherapy, the stats. That slide.
Yeah, yeah.
Yeah.
Rest of the slide, I hope you can see it. Yeah.
Yes, yes.
Yeah. So basically, why are we bothered about whether allergen immunotherapy is to be given to pregnant women or not? Now, this is a very common clinical parameter, clinical finding when such patients come to me. Because since I treat mostly adult patients, and many of them are in the reproductive age, so this is something which I face day in and day out. You see, 20 to 30% of reproductive age women are atopic. Again, from the statistics, pregnant asthmatics, about 33% or 1/3 of the pregnant asthmatics do experience exacerbation. Though in our clinical practice, this is slightly less, around 20%. These are Western figures, basically. 18 to 30% of pregnant women have rhinitis with or without sinusitis. This is seen, and this figure will be a bit more for our clinical practice in India. About 9% of the pregnant women have asthma. Pregnant women suffering from asthma have exacerbation during pregnancy. As we all know, during pregnancy, 1/3 of asthmatics have exacerbation, 1/3 of asthmatics have reduced features, reduced symptoms, and 1/3 remain the same. About 9% of pregnant women actually of asthma, who have asthma, actually exacerbate during pregnancy. So burden seems definitely to be quite high. But in one word, a green signal is given to allergen immunotherapy in pregnancy. Now, what do we expect? Why are we so scared, or why do we think so much about giving allergen immunotherapy in pregnancy? Because certain effects during pregnancy, like prematurity, abortion, hypertension. Pregnancy-induced hypertension is definitely an emergency, and that might occur during allergen immunotherapy. Proteinuria, teratogenicity, and finally, of course, anaphylaxis might occur, though it's very rare. These are some of the adverse effects we expect to happen. But what evidence do we have on hand? There are quite a few studies, quite a few large studies, about 10 to 12 large studies are there since 1978. However, the latest study was actually published in 2022. That was a Swedish prospective study. And this study went on from 2005 to 2014. The number of pregnant women enrolled in this study were about 9 million. Out of them, 743 pregnant women were given allergen immunotherapy. So what was found? The most important thing that was found in this particular study, there was no adverse pregnancy outcome at all. So what they concluded was, there has been no association between allergen immunotherapy and congenital malformation or any other adverse pregnancy outcome. And the second thing that was found was the incidence of allergic diseases occurring in offsprings of patients treated with allergen immunotherapy within the pregnancy period. That incidence did not differ from incidence of allergy in children whose parents have also been atopic. So, allergen immunotherapy does not alter the incidence of allergic disease in the offspring. And in 2012, one study was done, though with a less number of patients. And in that particular study, it was concluded that probably slit was safe even if it has been initiated during pregnancy. But this was the only study which had shown slit was safe when initiated during pregnancy, but this has not yet been this has not yet received robust attention. That's the reason why slit is also not started during pregnancy. Oh, goodness. Oh my God, why this is...
So we resume slideshow again.
Yeah. Can you see it now? Wait.
No, recommendations. You probably want us to see recommendations. So if
Yeah. Right.
Resume slideshow again.
Yeah. Resume share. And yeah. Can you see it
Resume
now?
slideshow.
You've done that only. Resume share, right? One second.
If you click on slide number 8.
Yeah, I have.
You've said slideshow.
Yeah.
No,
Recommendations. Can you see this now? No.
No. Can we go to the top and go to the top, and from beginning, if you go to the top of the bar, with your pointer, so can you say from current slide and see from beginning and then from current slide?
Yeah,
it's coming now. Recommendations.
Yeah.
It's on. Yeah, I can see.
Yeah, it's on, but I haven't.
Yeah, if we can go on with the recommendations, continuation of
You
AIT.
can read it, I suppose. Yeah. at
Yeah,
least.
we can say a saying.
Yeah.
We are saying, yeah.
So, from all these studies together, what has been recommended? That one is, if allergen immunotherapy is started, say about 2 to 3 months prior to the person becoming pregnant, it can be continued during pregnancy, and it is entirely safe both for the mother and child. Even though it has been seen that incidence of atopy or allergy in babies whose mothers have received AIT is the same as babies whose mothers have not received AIT. However, there is again one study which suggests that as immunoglobulin G antibodies cross the placenta, they might be responsible for decreasing atopy in the offspring. So this is something which they had hypothesized. It is yet to be proved in practice. A very important part of allergen immunotherapy in pregnancy is to monitor the mother who is receiving allergen immunotherapy, because if at all, if anaphylaxis occurs, then it is a bad situation both for the mother and the offspring. So whenever any minor symptoms of allergy appear, it's very important to reduce the dose. And so in certain cases, maybe immunotherapy have to be stopped. So monitoring the patient on a regular basis who is on allergen immunotherapy is a must. Now, venom immunotherapy itself is a risk factor for anaphylaxis as such. However, if venom itself is also a risk factor for the mother. So basically, before giving venom immunotherapy, one has to weigh the pros and cons of allergen immunotherapy in the woman. And depending on that, venom immunotherapy can be given, can be even started during pregnancy. However, the most important part is never ever start allergen immunotherapy in pregnancy, because there has been no evidence about the safety and risk of anaphylaxis if immunotherapy is started during pregnancy. Well, let us go on to primary immunodeficiency now. Yeah. So what is primary immunodeficiency? This comprises of actually a group of rare disorders. It is a genetic disorder. And this genetic disorder affects the immune system's ability to function in the body. So these patients have malfunctioning immune system components, with leaving them with reduced or no natural defense mechanism in the body. So primary immunodeficiencies are comprises of many different illnesses, out of which mainly antibody deficiency is the commonest type. Apart from that, there are certain immunodeficiencies affecting both the cellular as well as the humoral immunity. Certain deficiencies in the phagocyte number, diseases of immune dysregulation, complement deficiencies. So now if we go back to the slide where it was shown how allergen immunotherapy acts, we will know why allergen immunotherapy is not a regular choice for allergies in primary immunodeficiency. Now, amongst predominantly the antibody deficiencies, the commonest type of deficiency is actually IgA, immunoglobulin A deficiency, followed by common variable immunodeficiency. And when there is an IgA deficiency, what happens? Basically, there is low levels of immunoglobulin A. Can this slide be seen?
Yes, yes.
Okay.
IgA deficiency.
Yeah. Low levels of IgA. And these patients, these are the patients who cannot protect themselves against infections, particularly infections of the gastrointestinal tract and the respiratory tract. And the other common PIDs, which not exactly very common, but amongst the rarer PIDs, these are the commoner ones, a common variable immunodeficiency, where several types of antibodies are not present, or antibodies have a very low level in the blood. And this is probably the most common PID which is diagnosed in the adult population. And there is another one, severe combined immunodeficiency. And these are the patients who are extremely vulnerable to infections. Now, I would like to mention here just one particular line which I just came across. That was the first and likely the most relevant cause of failure of allergen immunotherapy is a genetic or epigenetic polymorphism of the cells and molecules who play a role in inducing tolerance to allergen during allergen immunotherapy. Why this particular line is important is this has a role to play in primary immunodeficiencies and their response to allergen immunotherapy if given. So, allergen immunotherapy definitely is not a primary treatment of immunodeficiency disease. Because in the primary, the immunodeficiency disease that involves the immune system, and in them, because of a deranged immune system, the allergenic responses are basically unpredictable. Again, in case of PIDs, if at all anaphylaxis occurs, then this anaphylaxis is very, very difficult, and it's a complex situation to manage this anaphylaxis. So, in some individuals, they have allergies. Some individuals with PID, they may have allergies and they may benefit from AIT, but this is not the primary treatment. So what is the primary treatment of PID in any cases? Basically, managing the infections or preventing the complications of immunodeficiency. However, many such patients with PID can experience allergic symptoms like allergic rhinitis or asthma, and they have a confirmed IgE-mediated allergies, and they do not respond to the usual medication given for IgE-related allergies. So in these patients, probably allergen immunotherapy can be of use. However, because of complications and because of risk of anaphylaxis, these patients need to be monitored by specialists who are specialists in managing both primary immunodeficiency as well as allergen immunotherapy. So basically, in primary immunodeficiency, role of allergen immunotherapy is not much, as we have seen. However, in pregnancy, it's quite a safe way to continue giving immunotherapy if that benefits the patient. Thank you very much for your patient listening.
Thank you, Dr. Oratrika, for summarizing a very difficult topic as effectively. And we are going to end today's discussion with a panel discussion. And as we are obviously short of time, but we have experts with us, my aim would be to ask some of the very pertinent questions that is related to allergen immunotherapy, and questions that we pediatricians, allergists ask. So I will be going from Dr. Krishna Mohan to Dr. Shoibal Moitro and Dr. Oratrika. I hope you're all here. And Dr. Krishna Mohan, sir, are you here?
I'm here, yeah, please.
My first question to you, because you stressed on the studies that we have and which we were referring to as examples and as data for immunotherapy in children. But do you think that there are a complete paucity of studies, especially multi-center studies in India? So we are not having, nationwide multi-center studies that would have been really effective in creating a kind of standardization for what we should do. What do you think? What are your thoughts? And can we do something about that as as a Indian Academy of Pediatrics Allergy chapter? What are your thoughts on that?
Yeah, I agree with you. I 100% agree with you. We as of now, we do not have enough studies, Indian
Mhm.
studies, to support not only immunotherapy, even in the skin prick testing, or even in the food allergy, or any form of allergy. We do lack studies. So as you mentioned, we need multicentric studies, good quality studies, that too with the standardized surgeons, because even now in majority of centers, we are not using the standardized allergens due to the lack of availability. So all these needs to be corrected. So as you mentioned, IAP can do, the allergy chapter of IAP can do. I think even by now, Dr. Neeraj himself has started some initiatives in that direction. One guideline is, a workup for that is going on. So similarly, some important step needs to be taken in that direction. We need to have good quality studies. Yes.
Because now we have sub chapters of the society all across India, more or less, and it's growing day by day. So it would be great, as you are the past president and the present president is also here, that we take a kind of initiative so that multi-center studies can be started and standardization can be done. My next question to Dr. Shoibal Moitro, and especially as Dr. Mohan also said, that there is a lack of the universal availability of EpiPen all across India, and there are indigenous variants. We can get some of online or imported, but there was a discussion in one of the panels that there was a variety of EpiPen being developed for India by a biotechnology department, I think, in Hyderabad. So, if I would like to share your opinion. I would like you to share your opinion on that. Dr. Moitra, are you there?
Yes, yes. Okay. Can you see me? Am I
Yes, I can see you. Yes, you're in the car. Yes, hello.
Yes. So sorry. Yes, yes, Dr. Day. Means we have all means discussed about it and talked so much about it that one of the most unmet need in our country is the non-availability of the adrenaline auto injector. Okay, that's very true because anaphylaxis, when you talk of anaphylaxis, we know that this is treated is only by the adrenaline. And more the adrenaline becomes available to the patient in the hand during a time of need, we can actually prevent death in the anaphylaxis. But at the same time, I would like to bring a very important concept as per the landscape of the allergy disease and its treatment in India is concerned. So there was a big discussion quite recently in one of the government forums, okay, where I was a part. So I was listening to like what are the questions being raised as means regarding this availability of the autoimmune adrenaline auto injector. One question which I feel is very valid is when we are giving the adrenaline auto injector pen to our patients, okay, that means we are giving the treatment or we are empowering them to treat their anaphylaxis during the time of need. Issue is, are our patients are capable enough to diligently utilize that power or not, number one. And number two is that, will it going to lead to the misuse and the overuse of the adrenaline in the context which may not be anaphylaxis. Okay, this I'm just talking about the product context of the India. So there was these issues which was coming up. Okay, so well means everybody said that no, we have to even if you save one death of anaphylaxis with an EpiPen, it is worth giving even 1,000 and not needed anaphylaxis, not needed EpiPen injection. That is always there. But the issue is, we are as a citizen of the country and the doctors of the country and for the society, we actually need to actually spread this awareness of the disease. We need to make like the students and the lay person and the doctors, everyone, okay, to understand what is anaphylaxis, symptoms of that, and how to treat them. So this patient education and preparing the ground to have or use the EpiPen adequately in our country, still we need to go some kilometer we still need to walk. Okay,
I
so
absolutely, I agree with that. I think we need to take a step forward and not a step backward here. And I am actually grateful to Dr. Neeraj Gupta, our current president, Dr. Krishna Mohan, also our past president, who have taken initiatives in spreading the cause of allergy, allergy knowledge, involving the common man, because if you have been following in the webinars, we are having situations where people with allergy, patients with allergy, and laymen are being involved. So the news is moving and knowledge is spreading, and we are empowering people. And so by the time we are well into the first year of doing this, of involving the layman, I think we will be ready to use EpiPen more widely. And as you have said, it could be misused, but it's well known that even if it's misused, it's hardly like to cause any problem. But if it's not used, it can lead to death. So I think there's a way forward for that. So there is the cost of EpiPen far outweighs the need for it. And if we are using it correctly and we are giving good advice to our patients, I think we have, eradicated polio. It's probably something, it was a huge task. This is probably a much smaller task. Now, the other question, my next question to Dr. Oratrika is, like, I have seen you practice in hospital settings, and I have also seen you practice in clinical settings. And I will come with that question to all the panelists today. Dr. Oratrika, are you there? My question would be, in both the settings, you are doing immunotherapy and allergy testing. Now, in a vast country like India, if we are going to set up immunotherapy clinics, then we might need to move out of hospitals onto clinical settings, chamber settings or a small outreach areas. If we need to move wide and move far, but what would you think is the challenge there? Because, on the background, you have the possibility of having an anaphylactic shock. Do you think it is safe to do immunotherapy in a smaller center? What will happen if a patient has anaphylaxis? What are your thoughts on that?
Yeah, thank you, Dr. Shamjukta. You see, what we were discussing now is regarding EpiPen.
Mm-hmm.
For example, this is an example I'm giving you.
Mm-hmm.
In a small place, since EpiPen is not widely available, what do? We sometimes keep adrenaline injections and the diluent there, diluting the adrenaline and giving it in the ratio of 1:1,000. It doesn't take really much time, as EpiPen is not widely available. Now, in a hospital setting, it is always safer to give immunotherapy and in fact do a skin prick test also than in a clinic. suppose. But in a clinic, like as in my clinic, I can talk about it. That is, we always keep a crash trolley ready, always. Because maybe once in a blue moon, we find a case of anaphylaxis. But then one should be prepared for it at that particular time. We don't know when it's going to come, when we are going to face the situation, but we have to be prepared for it. So it is definitely a challenge giving immunotherapy in a clinic. But yes, we should be fully prepared. Even the doctor who is present there, whoever the doctor is, doctor should know the finer points of resuscitation, finer points of approaching an anaphylactic patient, and at least giving him that much time to be rushed to a hospital. So that's it. One needs to be extremely careful. But in so many years of practice, I have seen, yes, I have seen vasovagal attacks. But God forbid, anaphylaxis, I have not yet seen. That's it.
I have unfortunately seen one, not in my clinic, but in the clinic next door. But we were working in a tertiary center, so it could be dealt with. And
Yes.
actually, the patient ended up needing to be intubated and ventilated. So after having seen that, my question to Dr. Krishna Mohan sir is, you have worked in good government setups, you're still working, you are probably doing immunotherapy in clinical settings as well. So do you think legally, when we are doing immunotherapy, we should have a fully trained nurse, somebody trained in basic life support? What is your thoughts on that? Because if something went wrong, when we are setting up clinics for centers for allergen immunotherapy, there should be some guidelines. So if our Indian Academy of Pediatrics is setting forth some guidelines, do you think among that guidelines should be the presence of a fully trained nurse, presence of technicians trained in BLS, apart from the crash trolley? What are your thoughts on that, sir?
So if you are going strictly by the recommendations from the international as well as the national guidelines, what is given is that all these strict presence of all these facilities is mainly meant for when you are doing a skit. But when you are practicing slit, that is not that much necessary, at least,
Absolutely.
except for the first dose where you need to observe. But as far as possible, if you have the availability of all these facilities, it is well and good. But when you are, so you mentioned one case just now. So was it skit or slit?
It was actually slit.
Slit.
It was actually slit, and I think I don't know. I feel, I mean, this is strictly off record. Maybe all the other prerequisites were not properly met. That is what is again, I think, so very important, that FEV1 should be more than 70%. It should not be badly controlled asthma. So these are the prerequisites that should be ideally met completely. So it can happen that just being a little negligent about one point might lead to a severe reaction. So I think mentioning all the guidelines, or taking out clear-cut guidelines from the allergy chapter would be really helpful to maintain a uniformity of practice throughout India.
Yeah.
So that would be helpful. And the other question, since you sir mentioned slit, for slit, it can be done for 2 to 3 year age group. There are recommendations, but as we have heard in various talks, that they can suffer with slit. You can have a bit of swelling under the tongue. You can have local reactions. So the main disadvantage, don't you think, is that 2 to 3 year olds may not be able to report those side effects?
Yeah, that is true. So even when I told that, I specifically mentioned.
Yes, sir. You mentioned.
Cutoff age is 5 years, but in certain circumstances where you definitely feel that immunotherapy will help, you can start as a lower age also as a special case on an individual basis. So there you have to be very much careful. You have to instruct the parents to look for the side effects. For example, suppose the child is a small baby, he may not be telling that he is having some itching. He may be crying for that. He may be presenting as an excessive cry. So all these situations you have to take special care. Otherwise, you may miss. So, in my personal practice, to be honest, I am starting only after the age of 5 years. And even for 5 years, even for slit, even though I'm practicing in a clinic in my evening practice, I make sure that for the first dose, I take the patient to a hospital setup, and only from there I give. I'm attached to a hospital also, and only from
Yes.
there I give the first dose. After that, only they continue.
Another question for my knowledge is, sometimes, as we have talked about, is that the child may be on a restrictive diet because of various possible allergies. So when we are doing slit or skit, would you recommend them to continue on the restrictive diet? I mean, then how will we assess if things are working or not? What is your take on that?
Okay, so that we need not have to mix up with allergen immunotherapy. Even when we are considering food allergies separately, we know that we need not have to impose unnecessary dietary restrictions. Only if there is a strong history suggestive of a food allergy, you have to do the test. I mean, either a skin prick test or an in vitro test. And if it is only supported by that, you need to restrict a particular food. There is point in empirically restricting all food items. That applies the laws that we follow in the food allergy, that applies here also. There is no specific thing related with immunotherapy. We need not have to unnecessarily restrict. Madam, your voice is not heard.
Yeah, Dr. Sanjukta, you are muted. Can you please unmute yourself?
Sorry, yes.
Yeah, no, it's okay.
Yes. Another question from my side is that if a child on immunotherapy, continuing immunotherapy, either skit or sklit, this is a question for all the panelists. They have to go on oral steroids for, say, a severe episode of or moderate to severe episode of asthma. Would we consider stopping immunotherapy for a few days, or what would you recommend?
We can continue the immunotherapy. We need not have to stop it, because is it like that only, sir? Moitra, sir?
Yeah, actually, if we talk in context of the skit, okay, if the patient is on a maintenance phase, we are not needed to stop the maintenance injections. If the patient is on a build-up phase, then obviously we would, if patient has an exacerbation or an acute episode of say asthma or something, we do not give give the build-up injections. We actually control the asthma, and after the asthma is controlled, 1 week or 2 weeks after that, and we are doing the PFI, it has come to the green zone. Patient is symptom free on regular controller medications. We start with the build-up injections. And what build-up injections, what dose we start, it all depends on how many days we have missed from the scheduled dose. So that is how it goes for the skit. Slit, the things are not as clear-cut defined as in case of the skit, because in slit we know from the day one we start with the effective or the therapeutic dose. So whether that can be given during an exacerbation and of an asthma and the patient is on, there's no clear guideline for that. And but to take it from actually the skid guidelines, we can just we can just extrapolate it to that, because any asthma which is uncontrolled in exacerbation carries the increased risk of anaphylaxis. So maybe at the time during the asthma exacerbation, there's an increased risk of anaphylaxis, and that anaphylaxis can get heightened even with a drop or tablet like the slit. It's always better we avoid the drops or tablets during that time, get the asthma controlled, the PFR in the green zone, and start it, the tablet or the drops later.
And when we restart, we have to start at a lower dose also, I think. The built-up phase, even if it was
Actually, the problem is, with this, if you just take in the context of the Acarizax, okay, they do not have any lower dose. It's a single 12 SQ or sublingual dose, okay.
no, subcutaneous skit.
Yes, obviously, it depends. Means we have an algorithm for that. Like if there is a dose is missed by the 1 week, we just go ahead with the same next dose. If the dose is mixed by 2 weeks, we just half the dose. We go by 3 weeks. Means this is the simple ballpark. In 3 weeks, we actually
One-third.
half the one-third the previous dose, or if we go by 4 weeks, half the previous dose. More than 4 weeks, we restart from the beginning. So that's how the schedule is. Okay. So that's the
Thank you very much for that. Before concluding, I think one concluding remark from my side would be that we should have an effort, as we are having so many webinars, to have standardized guidelines for everything mentioned about immunotherapy. So the standard of practice is same all through India, and we have a better allergy practice build up. We have more research work, and we have more training in allergy, which is very much required. And I would like to invite Dr. Neeraj Gupta for his concluding remarks. Dr. Neeraj Gupta, sir, if you would just opine about today.
Can I just add one
Yes,
thing?
of course.
Yukta?
Of course.
I would truly reiterate what you have said, because it gives the answer to your first question, which Dr. Krishnamohan has so nicely stated, that why we are not getting enough data on the AIT from India. The need is that until and unless we have a clear guidelines of the AIT to be practiced in India, what happens is that if just one embarks into a clinical trial in AIT, the ethics committee is not going to give the approval. So
Absolutely.
that's where we lag. So until unless we have an ethics approval, we cannot go ahead with any clinical trial related to the AIT. And also, if it has to be multicentric, there has to be harmonization of the practice all over.
Absolutely.
For that, we need a guideline, which is very, very needed in today's time to actually build up more data on AIT from India.
So basically, uniformity of practice, ethical
Absolutely.
considerations, and
Yes.
multi-center trial.
Exactly.
And so-
Dr. Sanjukta,
Yes.
just one thing I'd like to add is, see,
Yes,
even
please.
though allergen immunotherapy had been there since 1 century, more than that, in fact, 1911, and this is 2025. Still, in the GINA guidelines, it took GINA guidelines so many years
To include it.
recommend allergen immunotherapy in 2023 first, and then now they are recommending it. So I think allergen immunotherapy is going to be on the rise.
Absolutely. That is the
Definitely.
reason we need more guidelines, more uniformity, more research, so that we can go on to multicenter trials with proper ethical approval. Otherwise,
Right.
we will never generate Indian data.
Right.
And Dr. Neeraj Gupta, sir, if you're there, a few concluding remarks for tonight.
So first of all, I would like to thank Dr. Sanjukta ma'am. I think this was a excellent moderation, which I have seen. Means like this was definitely a difficult topic, and handling the, you can say like the top class speakers like Dr. Saibal Maitra, Dr. Ratrika, and Dr. Krishmohan is not an easy task actually. So, but you made it so simple that like the discussion was really, I was actually enjoying every part of the discussion, every bit of the discussion. I completely agree with you. And I think you all will agree with that over past, you can say like couple of years or probably 3-4 years, the talk in the town or the talk in the country is increased. It has, you can say like reached up till the masses. We are able to now touch our bases to community, to schools, to different other places. So that means definitely we are able to now, you can say like reach the awareness campaigns to the masses. We have also submitted our first, you can say like the official practice guidelines, rational allergy practice guidelines to Indian pediatrics for publication, which has been submitted last week only. And I completely agree that I think now this is the right time that we should now talk about not only the allergen immunotherapy, even you can say like the allergy testing and allergen immunotherapy and certain avoidance measures and all those things. So I think this is the right time that we should now start working on that. And if we can get this also published in probably sometimes later, you rightly mentioned that we are right now getting, you can say like nearly 50% of Indian states, they have already adopted the state branches. They have already made the state branches in last, I think, 7 or 8 months time. So I think this is really going to increase, and I am very much sure that entire country will definitely join us. All people, all our colleagues will definitely join us in this I will say initiative. And I think once we will be having the guidelines, then we can definitely plan for some uniform studies across the country, and we can definitely generate some data. And I hope that over next 2 3 years we should be able to, you can say like, get the things right on the track. And with the people like Dr. Saibal, Dr. Atrika, and Dr. Krishna Mohan to guide us for these particular areas. And I think we should be able to do that. So I would like to thank each one of you from the bottom of my heart. I really enjoyed all the three talks, and especially the moderation by Dr. Sanjukta. I really loved that moderation. And thank you very much. And with this, I think we have now completed 4 webinars of this series. And now the fifth one is something like future. That means once we are prepared, our patients are prepared up till this extent. And now we have to really think about something new, something different. That could be some biomarkers, that could be some newer modalities of immunotherapy, or even there was some discussion about food allergies, which are rising and they are bound to rise in this part of the world. So, can we do something for food allergies related to food immunotherapy? So, we will definitely have a good discussion. So, the next webinar will be planned for 8th August, which is on Saturday. So, sorry, which is on Friday, 8th August, which is on Friday. So we will meet you once again at 8 p.m. on 8th August. Till then, thank you very much and goodbye and good night. Thank you.
Thank you, sir.